Good to go?
I figured probably it was so it's like between 2 o'clock and 9.
Hi everybody, thanks for coming to the Alumni Seminar series today. Today we'll have Dr. Kevin Keck. He received his Bachelor of Science in Civil Engineering from UC Davis in 1970. Then he got a master's degree from UC Berkeley in Material Science and Engineering. And then he came to medical school at UC Davis, after which he did residency in internal medicine and pediatrics. And I'll let him take it from here.
Thank you all. Thank you for inviting me, and thank you, Gina, for being a great host for me today. I have enjoyed looking at what you do here, and it is truly impressive. What we're going to talk about today is an area of expertise that I have and an interest in healthcare policy. And what caught my eye and got me interested in this is looking at the magazine that comes talking about what you do. And I thought it'd be interesting to go over how healthcare works in America. And you're going to see that it can be better. Now, in a disclosure mode, I have no financial relationships to report, and this may be the most important slide in my talk, that although I have worked for pharma, for medical groups, for health plans, and I worked in a hospital system, nobody pays me. And so I'm going to give you the view that I've got without an agenda. Now, my pathway to get here was with this, UCD Civil Engineering. I was one of the pioneers, if you will. I was starting in 1966, and Dr. Schroeder, who will be here in a bit, came same year, and he has and is my advisor. I got my master's at Berkeley, and Grandma got sick is the catalyst that is why I'm here today. I was 22, she went into heart failure. I thought that was pretty cool watching what was going on. I had toyed with the idea of medical school up to that point, and applied and got in. And I graduated from Davis, UC Davis in 1975. I did training as a pediatrician internist at Children's Hospital and Sac Med Center. Practiced and lived in Kaiser, and then my physician executive work began. I did that for over 25 years. And I have experience leading a 100 physician group at Kaiser Sacramento. I was Chief Medical Officer of Providence Health Plans, and I was involved and steeped in all aspects of managing the population. I consulted with Eli Lilly for a few years, helping them with their planning of phase 3 studies. And now I'm a part-time doctor, and I work in the emergency department and palliative care, end-of-life care. So, getting into health care, this pie chart is really, really important, and not the specifics, the trends. I'm going to show you it again later in my talk, but this is where the dollars are spent in healthcare in the United States. This is a commercial plan, and I'll explain to you the difference between commercial and senior. But the points to look at are that if you look at the chart starting at 12 o'clock here, going this way, all this is care that's done in the hospital, and you can see that that's about half of the healthcare dollar, and that you can see that there's no one area that dominates. That's important. And then the physicians, this is physicians from here to here, it's about 15–18% of the healthcare dollar. That's what the doctors receive. Pharmacy and injectables is about 20%. This is a little shy, it's a commercial product, but pharmacy is 20%, and then imaging is around 8%. Okay, big sector and growing, and this is the rest of it. In understanding healthcare, when I learned this pie chart and had it on the tip of my tongue, it really became helpful. So what we see is that about half the costs are in hospital or facility. 17%, 18% cost is drugs. Small molecule means amoxicillin. Large molecule are the injectables, Remicade for rheumatoid arthritis, etc. 8% imaging, 15 to 18% to physicians, 1% in durable medical equipment. Now, this is your primer, your lesson in how commercial insurance works. And understanding this will help you to understand what's going to happen with the Affordable Care Act. And the way it works is this is for people under age 65. The employer is the one that purchases this. Costs are poorly regulated. Okay, this is where entities make up for the losses on Medicare and Medicaid. The insurer negotiates contracts with hospitals, doctor groups, pharmacy, and the insurer often negotiates with a monopoly or oligopoly. Think of if you're Blue Cross of California and you need to negotiate for a hospital, you're negotiating with Sutter, and that's an oligopoly. You have to have it in the network. Okay, so in government, this is for the aged and the poor, and Medicare is for age 65 and older. Medicaid, which we call Medi-Cal here in California, is based on financial need. Costs are highly regulated. Okay. The government is the risk taker. And you've heard the term perhaps Medicare Advantage. That's the risk-taking entity, and they're all called Medicare Advantage, where the insurance company takes the risk. Now, the way the dollars work, how payment is made, is done by this system. With physician groups, there's a relative value unit. Okay, so if you see the doctor for a colonoscopy or an operation, craniotomy, sinus infection, blood pressure check, there's a code for that and a relative value unit. Okay, and then hospitals, there's a relative value unit for each hospitalization, which is paid in a prepay manner with this name, diagnostic related group, or DRG. And then there's a conversion factor in dollars for each RVU. Conversion factor times RVU equals payment. As engineers, you're going to understand this, that you multiply the number of units of work you do, which are defined by the value, and you get income. So the conversion factor is set by the government, Center for Medicare and Medicaid Services, for Medicare. It's set by the state for Medicaid, and it's negotiated hard on commercial. So here's the outcome. And I say this is a physician payment example, and I say what's wrong with this picture. And the commercial insurance, Medicare insurance, Medi-Cal insurance, the RVU conversion factor, that is for the payment for the work on the commercial. This is a typical market conversion factor for commercial. This is set by the government. It's that right now for Medicare. And Medi-Cal is around $12. So for sinus infection, if I see a patient for a sinus infection and that patient has Medi-Cal insurance, then I get paid $24. If that patient has Medicare insurance, I get paid $70. If the patient has commercial insurance, I get paid $140. So you can see the discrepancy. And then the numbers follow through. This is linear. Total knee repair, physician gets $3,000 for doing it on a commercial patient, $500 for doing it on a Medi-Cal and colonoscopy. You can see the differences. And then same thing for the hospital, that if the hospital takes care of a commercial patient with pneumonia, because the hospitals are paid by the diagnosis. In other words, not the number of days the patient's there, but by the diagnosis. Each of these has a value. Then the conversion factor is currently this. It's 53.43. So the conversion factor it pays for pneumonia $5,000 for a Medicare patient, double that for commercial, and Medi-Cal is a fraction. So you can see how hospitals have to deal with these differences in payment based on who the insurer is. So what happens? What's the outcome with this system? And these are some financial outcomes. But follow the money to understand what's going on. And you'll be able to do this with the Affordable Care Act when it comes on the scene in a few months. The more services, office visits, and surgeries provided by doctors, the more income you make. All hospitals lose money on Medicaid, right? So they have to make that up somewhere. And then hospitals lose money or break even on Medicare. So they have to make that up somewhere. And then we have a volume, not a quality-driven system. Every system is perfectly designed to get its outcomes. So the outcomes we get are because of this payment system. Now, doctors and hospitals are very often monopolies or oligopolies when negotiating. The more you are a monopoly, the higher you can charge. You go down to the hospital in Salem, Oregon. I'm from Oregon part of my time, and the hospital administrator sits there and says, we need 13% increase this year. Well, why? Because we need it. And they know that we have no choice because they're the only hospital in Salem. All right, and so this is not a free market negotiation. You know, we can't tell Salem Hospital, we're not going to contract with you because we can go to the other hospital. You can't in Salem, Oregon. Okay, commercial contracts, this is, I think, the important point of what I'm talking about with all this is commercial contracts, the dollars that physicians and hospitals get from the commercial contracts make up for the losses on the Medicare and Medicaid. So, and then if the patient has no insurance, we call that self-pay. And the recovery of a bill to a self-pay patient is in the single digits. They just don't pay. And then doctors and hospitals extract dollars from the commercial contract to cover losses and inefficiencies with all lines of business. Now, the outcome of all these dollars adding up is this. And this is a slide of the difference between consumer price index and medical inflation. Now, I got these numbers directly from U.S. Bureau of Labor Statistics, and I took them straight up. I didn't bother to do any further refinement. I read that the medical inflation gap in 2012, this was a partial year when I made the slide, is less than that. It's more like 2 percentage points. But this gap is cumulative year on year. And right now, because of that gap, whoops, where was I? Okay, let me do this slide. Because of that gap, it's 17.9% of gross domestic product. That's a huge chunk for a country to pay, a huge chunk. And it's $2.7 trillion in 2011. I read that this dipped in 2012 because of growth of other sectors of the economy. About 50% more GDP than other developed nations, 2.5 times more per capita healthcare expenditure. And I put this in because I was working with the governor's representative in the state of Oregon, and he proposed, you know, what about K through 12? What about Social Security? What about the mortgage retirement? Where is the opportunity cost because we're spending all this money on healthcare? 30% of care is wasted, and that's pretty easy to prove. And there's a guy named David Wenberg who publishes out of Dartmouth University, Dartmouth Dallas, and he crunches Medicare data for a living, and he can show the variation. I'll show you a slide out of his atlas. And we are on a bubble. If you take a look at what was going on with .com or real estate, with those kind of bubbles where the value isn't there, what happened? When are we gonna have the crash in healthcare? So let me go back one. That now, as far as what are we getting for all this money? And it's this, that American healthcare gets it right about half the time, and that is measured examples of blood pressure, diabetes control. About half the time, regardless of the type of insurance. In other words, you'd think that if a patient had good insurance and high blood pressure, that their blood pressure would be in control. No, this is the outcome. And this was measured in a Medicaid population. They came out with the same outcome. So we're not getting to goal in blood pressure, diabetes, cholesterol at best level, getting a mammogram done. Our batting average as a country with 5 elements of diabetes, hemoglobin A1C, urine protein, blood pressure, those we get that right less than 1 time in 5 as a nation. And then mammography, we're doing better with that. The mammography prevalence is about 80%. 80% of women who should have a mammogram get it, but it's not 100%. And then the blood pressure has been measured. About 1 in 3 patients will get blood pressure at goal if they have insurance. Is this acceptable? Now, quality outcomes used in international comparisons like life expectancy, infant mortality are mediocre. U.S. death rate before age 75 from treatable chronic conditions is worst among developed countries. So if you have diabetes or heart failure, lung disease, chronic obstructive pulmonary disease, your life expectancy is poor in the U.S. And it's not because we're bad doctors. It's because of the payment system creating the incentives which don't lead to these outcomes. Now this is an example of Dartmouth Atlas. Yes?
Sorry to interrupt. I just wanted to get some clarity. What do you define as right when you say gets it right?
If a patient has insurance, you look at the medical record, they have high blood pressure, and you look at the blood pressure, and it's less than 120/89. Okay, that's getting it right. Or if the patient has diabetes, is there a hemoglobin A1C on the chart? Is there a urine microalbumin? Is the blood pressure recorded? Is the cholesterol recorded? And are those at goal? Okay, that's what getting it right means. We know that if you have diabetes, coronary disease, a strong family history, your LDL cholesterol needs to be less than 100. We look at that, and that's the getting it right. Now that's a generous number, by the way. I met the person that wrote the paper. This is out of RAND, and I said, you're being pretty generous with this, aren't you? The way they did it is on some of these is a telephone survey, and she said yes. The actual outcomes are probably the ones that really prevent disease are probably in the 1 in 3 that happen. Now this is the spine surgery slide I was telling you about at lunch today. That this is what the Dartmouth Atlas looks like, and this is the higher it goes here is the surgery rate, surgeries per thousand, and then these are the number of geographic areas that have that surgery rate. You can see the bell curve there, okay? And this dot right here was Bend, Oregon, and I had to deal with that. And as a medical director of the health plan, and the fact that the surgery rates are so high in Bend, Oregon, which is right here, is not because their spines are sick, that they lift too much, or they have genetically more Carter disease. No, that's not it. It's a function of a neurosurgeon being there and a hospital operating room being there. And this kind of a variation is unacceptable. And it's here because the surgeons are paid by the operation. That's the flaw in the system. So, let us look at what happened in Massachusetts. Now, Massachusetts, Commonwealth of Massachusetts, decided back 10 years ago that they were going to have universal coverage for their population, so they went ahead and did that. And they created insurance exchanges. They created penalties for not having insurance that were small to start, large after a while. And this is the model that the Affordable Care Act is modeled after in our country. This is Obamacare as the laboratory of the state of Massachusetts. So what they did is they covered 98% of citizens. And I talked to the guy in charge of the exchange, and I said, what are you guys doing about, or what did you do about the cost of all this? And he says, my job was not to worry about cost, my job was to get everybody insured. Okay? So what they found is costs were out of control within 2 years. And this is a state that cannot print money. All right, so they have to come up with a solution. So what they did, or what they found, a 57% increase in premium between 07 and 12. 2 years into the program, or 3 years into the program, they created this roadmap to cost containment. They knew they were in trouble, and so they created this roadmap to cost containment. And think about the organization or systems of care that are being talked about, the Accountable Care Organization. If you've read about the Affordable Care Act, they talked about changing payment structure. We're going to get this thing figured out. They didn't. So then, what happened is in August of last year, the state legislature acted, and they said healthcare spending is regulated to state consumer price index. Okay. Now, healthcare growth in Massachusetts was 6 to 7% a year. CPI, this is Massachusetts CPI, by the way. Theirs was 3.7, so they were clipping along at this. So they said we're not gonna pay you this anymore, doctors and hospitals. That if you are an oligopoly or a monopoly, and what comes to my mind is Massachusetts General, and I can just imagine negotiating with their CFO on their contract. Well, we're Mass General. We are where New England Journal has all of its case studies come out of. We are the Mecca of America, you got to pay us. And I'm sure they got tired of that, and they said, no, if anybody needs more money than Consumer Price Index, then they can be investigated by the Attorney General's office. So they're tired of it. And then the failure to meet this goal, unfortunately, is a small fine. This is small, but it's a step in the direction that they need to go. And $500,000 for an insurance company in Massachusetts is petty cash, but at least they're on the right direction. This should be more like 1% of their revenue. That would be $20 million. That would get their attention. Okay, but it's going in the right direction. So now the Affordable Care Act mirrors Massachusetts. California may have about, is that arrow in there the whole time? California may have a ballot measure in the next 2 years for the same benchmark. We can expect other states to follow. And in our system, the best way to regulate costs directly without a lot of political capital being spent is to regulate revenue. And single payer which means the government takes over. Think of England or Canada. It's not going to happen in the United States. There's too many political forces that would kill that before it would get through Congress. So how do other countries manage? We hear about Canada, we hear about England, Cuba, we hear about European nations, and France, fees are regulated. In Germany, strict controls on fees and payments. In Japan, rigid control of costs. There's a pattern here. In United Kingdom, England, and Canada, they come up with a national budget. In India, which is primitive compared to these other nations, it's out of pocket. Patient pays out of pocket. So other countries that we hear about, these other systems, that there's pieces of it that we always like. Like in France, they have a credit card that has their entire medical history on it. And they take that to the doctor, and then everything is portable in the patient's wallet. So that's pretty cool. But the family doctor there gets paid $60,000 a year. Family doctor in the United States gets paid $180,000 a year. That's the difference. So if revenue regulation happens, now this is me speaking. What I've been giving you is from literature. This is me. Marginal hospitals and health plans will be left on the wayside. I think we can expect that. The DRG system, this is a measured outcome, resulted in improvements in hospital costs. It used to be that the patient came in and had pneumonia. You'd keep them 4 days, get them feeling better. You keep them 3 more days, make sure the fever didn't come back. That's 7 days. And then Medicare would pay for all 7 days. They said, no, we're going to, you got pneumonia. You take care of it. We don't care if it's 2 days. We don't care if it's 7 days. By the way, if that patient gets readmitted, we're going to keep track of that, and you need to be like other hospitals in that area. It was harsh, but it worked. Physician income's going to be impacted. I think it's going to go down. Early adopters of systems of care will do well. And I think we can eventually expect widespread adoption of systems of care for remaining healthcare entities. The 10-year timeline is my idea, just knowing how long it takes to get some systems of care in place, working, measured. It takes some time. So in the future, there will be opportunities galore. And if I'm a biomedical engineer, this is where my interest gets picked up, because healthcare delivery will be re-engineered. There's no other way around it, and it's going to be re-engineered, and I'll show you some things that I expect have happened, will happen. There will be capitated set amount instead of fee-for-service payments. Let me explain that. That if you came to see me for a sinus infection and you have insurance, I bill your insurance company $180. Okay, that's called fee-for-service. However, if your insurance company makes a deal with my medical group that will take care of you for $10 a month, okay, then you come and see me. I don't charge you $180. I get my money from the $10 a month, and that's got to pay for your laboratory, your X-rays, your times in the hospital, the whole smash. So I'm motivated to say, you feeling better? You're okay? Give me a call on the telephone if it doesn't help, and we can handle this by phone. I'm motivated differently if I'm in charge of your health care because I'm being paid $10 a month. And I get $10 a month from you and you and you and you and you, and it all adds up, and I get a different incentive to care for you than come and see me whenever you're sick. So systems of care will be created to improve quality. As quality goes up, costs go down. That's counterintuitive. Here are the data. And, whoops, yeah, I'm sorry. Data come next. But physicians and hospitals will need to create systems of care. The Accountable Care Organization, you'll read about this. What's going to happen with Affordable Care Act is you're going to read about some bad outcomes. That'll be normal. You're going to read about chaos. uncertainty. That'll happen for a couple of years. That's what happened in Massachusetts before it smooths out. So that's going to be normal. You'll read about the Accountable Care Organization. This is the organization that's going to receive the $10 a month. That's called an ACO. And these organizations will be physicians and hospitals. Okay, and data will be critical. I know you do biomedical IT, and I would encourage you to look at data that have to do with the dollars in this, because there's rich outcomes that can happen with that. And this must be done without rationing. The United States is not going to put up with rationing. In other words, you are stage 4 breast cancer, you have had 2 cycles of chemotherapy, we've given you 2 more, we're not giving you any more because we're rationing care. That's not going to happen in the United States. And then I think limiting revenue is going to accelerate the process. I always get asked about, well, gee, if we can just get rid of the trial lawyers, is that going to help? Well, it would help, but tort reform is not a significant driver of cost. That's not what this is. Here's the data on as costs go down, quality goes up. These are quality ratings this way, and this is cost. And these are old data, but it has obtained over time that those states that provide good quality, Utah, North Dakota, or here's Oregon, here's my state, it costs less per Medicare beneficiary than Louisiana or Texas. Don't get sick there if you don't have good insurance. Okay, so here's the pie chart again, all right? This is the last time you'll see it, but the slides will be available. If anybody wants slides, just ask and we can get them to you. But remember the pie chart, and if you take a look at how do you impact this, the first thing you say is, well, we'll just make sure all the pills are generic, because generic medications cost a fifth of brand medications, and we're going to save 3%. So then you say, well, okay, 3% of 13% is what, 0.4%? Nothing. No, you want to move the needle 3-4 points. In order to do that, you have to impact each one of these areas. Okay, and that's a key point, and that's again opportunity for you as biomedical engineers. You have the whole canvas to paint within because you impact one of these areas, it would be wonderful. And then you do that, they'll say, well, impact another one. So the roadmap, if you keep in mind the pie chart, is reduce medical admissions. And a medical admission is heart failure, lung disease, renal failure, pneumonia, infection, heart attack. That's a medical admission. Surgery is done when indicated. And remember my slide of the spine surgeries in Bend. They're doing surgery that's not indicated. So how do you incentivize the surgeon to operate when indicated? ED care transformed to mainly emergencies. 50% of all comers to ER can be seen in a doctor's office. Physicians compensated for outcomes instead of, if I see you for sinus infection and I'm measured, what percent of the time do I give you an antibiotic versus not? Okay. Sinus infection is 10 to 14 days of discharge of any kind, feeling crappy, not getting better, and the patient notices a decline. That's a sinus infection. Antibiotics help. 7 days of green snot and I have a cough. That's not a sinus infection. It would be helped by an antibiotic. So I have a batting average of how often do I use antibiotic. That's payment for outcome. And generic prescribing, 85% plus. Hospitals use hospitalists and intensivists. In other words, when you're in the hospital, you get an expert taking care of the patient who's in the hospital. Sounds simple. But the days of Marcus Welby seeing the practice in the office, going to the hospital, and then going back and seeing more patients in the office, that is inefficient. And it's much more efficient to have specialists in these two areas. Imaging done when indicated. I know that imaging is one of your research areas, and I'll tell you the full story of what's going on with that when I get to that slide. New technology rigorously evaluated. In other words, we don't pay for non-proven therapy. Patients empowered with data and incentive. And then there's always more you can do. Okay. So, all right, so systems of care medical admits. I'm going to speed up a little bit here. There's 23 chronic conditions, 60% of medical expense. And the method for managing this is motivating, educating, and empowering the patient to take their medicine. Sounds simple, but that doesn't happen. Population health promotion to prevent the chronic conditions. Here's why you shouldn't smoke, or smoking makes wrinkles. Whatever it takes to get to the adolescent's brain. Besides, here's the bad things. You talk about the expense. They can't go to the movies, or they're going to get wrinkles, or their breast stinks. That is important. And 1% of the population uses 30% of healthcare costs. Surprising statistic, isn't it? 30%, 1%. And then 18% of the population consumes the vast majority of healthcare costs. These are the chronic conditions, and I'll point out just a couple. Renal failure, heart failure, high-risk maternity, diabetic mother with hypertension that smokes. That's high-risk maternity. Okay. Surgical procedures indicated, and there are evidence-based reasons when you should operate on the spine, and the indication for an operation, upper endoscopy today or soon, for heartburn and pain with swallowing, bleeding, anemia, weight loss, recurrent vomiting. Right now, the indication, in a lot of areas, the indication to have an upper endoscopy is the patient has a history of a stomach ache. That's overuse of the service. Okay, preference-sensitive conditions where the physician and the patient make a decision whether it's needed, and this is the list. These are things you're familiar with: hysterectomy, GI endoscopy, looking at the stomach, total joint repair, spine surgery, imaging, and this is a large piece of the healthcare budget. Emergency department, I think I'll skip. I think I've touched on that. Physician compensation for outcome, I think I've touched on that. That I'll be compensated if I do well with this set of criteria. That did my patients with asthma and lung disease go to the emergency department? What that means is I have to be there Friday night. I have to be there Saturday, Sunday. How do you do that? Well, we hire a nurse call center to cover 250 square miles, and we'll have a physician on call that can help them. That would be a system of care. So these would be areas where the primary care doctor can impact important diseases like depression, overuse of antibiotics. If the patient comes with back pain, do not image it until you have to. Well, my patients need to know why their back hurts. No, they don't. You treat the back pain, get it better. Most of the time it's going to get better. You know what the red flags are. You don't have to diagnose what's going on with an imaging test, because that is a pathway to surgery. And does your patient need surgery? Okay, pharmacy, it's getting generic costs elevated. I'm speeding up here. Hospital compensation for outcome. There's a host of things that can be done in the hospital, and CMS is on this more than anywhere else, because that's where most of the dollars go. But things like having hospitalists, having high surgical volumes if you're going to do the surgery. The more the surgeon does, the better he gets or she gets. Never have a gallbladder surgery in the first 12 of a general surgery. Never do that because they nick things. So you always ask if you're going to get a surgery, how many of these have you done, doctor? It's a fair question. When I had my hernia done, yeah, I picked a guy who I had done training with 30 years ago to do my hernia. And it was was perfect. Okay, so compensation for avoiding complications. So skip that. Imaging, I'll spend a little bit of time with this, and I'm almost done, and I'll open it up for questions. That imaging has a high utilization without a healthcare outcome, and that's unfortunate. And what I mean by that is there's been a big growth in this 8% sector, and imaging is plain films and high tech. Imaging is plain films and high tech. High tech is CT, MRI, MRA, it's a PET scan. And the advances that you have created, that the bioengineers in America have created in the resolution of the imaging and the types of imaging have not translated to a health benefit. That's literature proven. So what do you do in this situation? That the physician needs real-time feedback in prescribing. In other words, if a patient comes in with worst headache in their life, and the physician asks for an MRI of the brain, that physician needs to be told, no, non-contrast CT, that's the imaging choice for this setting. So a lot of times the doctor doesn't know which is the correct image to get or when. We don't want an ownership relationship with the reading radiologist. When they own the high-tech machine, what happens is they'll refer to themselves, and they'll dictate in the report of the plain film. You need an MRI to further delineate what's going on here. And then it's not the machine's fault. I'll give you that as an encouragement. It's not the machine's fault. Keep going in the research in imaging. Keep going with that. And now that what you're looking for is imaging that is going to change the outcome of what the doctor does. That's the holy grail in imaging. Patient empowerment is giving them the data so that they know. Like I just told you, if you're going to have your gallbladder taken out, doctor, how many of these have you done? And it better be more than 12. New technology, there's a rigorous process that occurs. This is after FDA approval, where the dossier is sought of what does this new device or catheter or whatever do, and what is its safety record, where is there literature that says that it works, what else do we have, and is it better than existing? And this is a tough hurdle to get through, I guarantee you, a tough hurdle. And the best way to do it is to have a peer-reviewed study. But this is what happens after FDA approval. So unmet need, this is my list. I'll just go through this quickly. And there's a lot of burden of suffering still out there. And obesity is huge. Patient activation, this means the patient understanding and being motivated to deal with their illness. Smoking remains an issue in America. Dementia, large, sad issue. Heart failure is still a problem. Liver failure, usually from hepatitis or alcohol. Renal failure from diabetes. Lung failure from smoking. And then stroke and acute coronary syndrome, we still have a lot of burden with that. Biggest cause of death in America. Breast cancer screen, mammogram, turns out, is mediocre as a screen for breast cancer. Colon cancer screening is real good, but it's hard to do. If you ever had a colonoscopy, it's not the most fun thing you're going to do. We need a prostate cancer screen. The ones we have don't work. Chronic medication adherence, patients on a cholesterol medication or a blood pressure medication. What the pharmacy guys do to call this compliance is they look for 90% fill rate. That's compliance. So it's a problem. And then an alternative to the episodic office visit, coming to see me for a sinus infection. Is there a better way to do that? Insulin delivery systems, this is a problem. It's a big barrier getting the diabetic interested in injecting themselves. Okay, so I've left some time for questions, and I'm happy to answer. Any question you've got? Yes?
So I guess a lot of all of this focuses on testing and quality of care and you mentioned that costs go down once quality of care becomes better.
Right.
So how does tort reform play into all of this?
It doesn't. And oftentimes, there's a misconception that if we can just get rid of the malpractice lawsuits, then physicians won't do these unnecessary things that are driving the cost up. That's not the issue. So I put that in as a disclaimer. We got to look in other areas besides not having attorneys sue doctors.
And the Federal Care Act, or Obamacare, kicks in officially federally in 2016 or 2014.
Yeah.
So
10 months.
So that applies, Medicaid applies to people who are making less than 133% of
The free Medicaid provided by the federal government is in that group.
And do you happen to know what percent of the American population qualifies or is eligible for that?
I'll tell you what I do know, that about 1/3 of the U.S. population has no health insurance. A large chunk of that is working poor. I would say that probably a third of that chunk would be the poor. And this is very sad. As an emergency room doctor, it's so sad when these patients come in and I can do nothing except tell them to find health care or a free clinic at the county. So this will help that scenario. Yes?
I've worked in medical device manufacturing a bit, and again, sort of going off Smita's point of how costs will go down as quality improves. I've been in plenty of meetings where, prices are decided on these really arbitrary bars, like 6 times the cost of production, 7 times the cost of production. And I don't, in the discussions, it doesn't really seem like, say the cost of regulation or whatever have you is feeding into this. So how would something like that make those costs go down?
Yeah, it's with this. Remember the pie chart. If the whole name of the game in cost reduction is keeping the patient out of the hospital. Okay, so if the device can keep the patient out of the hospital, or if the device solves a problem, the device is a heart valve, patient no longer has heart failure, no longer is showing up here. Okay, a patient has total hip repair, pain is gone, no longer showing up there. Okay, and then a patient has rheumatoid arthritis, you put the device in, which is the hip, it doesn't show up there. So it's the costs that don't occur down the line. And one example I gave today at lunch was a kidney transplant is about $100,000. Okay, but if the patient is on dialysis, then they wind up here and there. They get strokes, they get heart attacks, they have to have their devices put in surgically, and then it costs $60,000 to dialyze them every year. So it's way cheaper to do that upfront cost because the patient's healthier, has a better quality of life, and then stays out of this part of the system. That's where it comes from. So don't be discouraged. I was asked that question about, am I adding costs with what my research is? No, you're not. If you have an invention, a device, something you're working on that creates quality when it's applied clinically. What we found most of the time, not 100%, most of the time when we improve quality, costs go down. As a matter of fact, when I did this across the board, I was hauled down to the capital of the state of Oregon saying, you guys are making too much money. What are you doing? Are you withholding care? No, we're just improving the quality of care and it flows to the bottom line. Do not be discouraged with that. Yeah.
So the commercial pay rate is higher than the government-based pay rates, as you showed?
Yes.
How does the government establish that floor, that payment floor, such that the hospital, the providers are actually needing to compensate somewhere else? Is the government leaving out the sort of expense? Or?
No, you're asking a key question, and they're doing what they can get away with. When Lyndon Johnson thought of this back in the 60s, they had no clue that Medicare and Medicaid was going to be so expensive today in America. And Clinton, during his administration, says, we're going to balance the budget, so we're going to take care of this. And so what they did is they said, if costs go up in a hospital side, we'll take it away from the physician. Now, the AMA every year lobbies Congress to get rid of that, and they were successful again in January of this year, 2 months ago, getting that money restored. So the way they pick it is, I think, what they can get away with. And the $35 on the conversion factor is just enough so the physicians will be interested in taking care of that patient. But I dealt with physician groups that cut Medicare. We're not taking you because you're Medicare, and they're only doing commercial. Now that's sad, but I'm sure that they take a look at this and they do what they have to do to keep the program going. But they can do a little more than that. And then the inefficiencies and the shortfalls are made up on the commercial contracts. Like that hospital in Salem, we need 13%. And they'll tell you, we're losing money on Medicare, we need 13% out of you so we can balance the books. And what do you do to increase quality? And they can't tell you a story. Yes?
So you were speaking about the flat fee approach, where the patient would pay like a monthly contribution to be taken care of.
That's capitated, and in a capitated situation, the patient pays the insurance company, and the insurance company then does that piece of it. Okay. But keep going.
But wouldn't it be easier to just like directly pay the hospital? I mean, what's the role of the insurance company in this case?
The insurance company is the aggregator of the network. They create the network, and they do the contracts, and they create the healthcare system that the patient can go into. And without that, somebody's got to do that job. Right now, that costs 10% of the healthcare dollar to create that. And that's been criticized. And matter of fact, that's part of the Affordable Care Act, is the amount that can be spent on that is limited to 20% of the healthcare dollar. Usually it costs about 10. Yeah, so the insurance company's role is to create the network that the patient gets care within. Yes?
Can you comment on the academic medical centers which are required to take Medicare and Medicaid patients at the, so that is part of their cost, and yet that's the place where some of the research that may help to improve this is done. You know, what's the future then? What do you see as the role of academic medical centers?
Okay. As far as the teaching rule, that's part of the Medicare Act. That's black and white law. And when there's interns and residents, that's paid for by Medicare. Academic centers often suffer from a poor patient mix. So you take care of the poor and the patients that can't pay. In the scheme of things, when all this is being talked about, they always talk about the teaching hospitals. So teaching hospitals will get recognition for what they do. What this looks like for a teaching hospital, I don't know. I was asked about is there going to be a cutting back of research? I don't see that, because we have to continue the research and the innovation to keep going, because there's so much unmet need out there. I see that going forward. But I think the academic medical centers are going to be hit with the top line revenue hit that I described. It's going to happen everywhere else. But there is a soft spot in Congress's heart for academic centers, so don't worry. They will be taken care of. That in any discussion of healthcare reform, they've always been appreciative of what the academic medical centers do. It's always been there. Yeah.
We have one more question, if anyone else has one, or?
Yeah, yeah.
You said 1% of the people account for 30% of the cost.
Right.
The other was 30% of people account for 80% of the cost?
18% of the population is 80%.
Who are those people, and can that be changed?
Okay, the one percenters, are, you know, think of leukemia, breast cancer, heart failure, Gaucher's disease. They're the ones with a chronic illness that's ill, or somebody that's been in an accident and is now a quadriplegic. That's the 1%. The 18% are patients that have been in the hospital, have been to the ED, are on 2 or 3 medications. That's the 18%. The whole boat is floated by people like yourselves that pay money, or money is paid for you into the budget, and that money is used to pay for the sick people. That's what we call the principle of insurance, that you have to spread the risk so that the 1%ers can be cared for. Everybody's got to pay something, and that's the principle of insurance.
Well,
Ed, by the way, is my advisor from when I was a student here, and he and I came to Davis together, and I should have mentioned that he's been a great mentor for me my whole time here, and we remain friends to this day.
I'd like to thank Dr. Keck for coming today, and a little plaque made up for you that recognizes you for your contributions to biomedical engineering medicine. So thank you for coming today and speaking with us.
You're welcome. And,